Okay, so intra indications. Why do doctors send us? As you can understand, many places don't have the stereotaxy. They are going to do blindly. The head position may not be correct. So they want to know whether they're actually in the lesion or not. That's the first thing they want to know. Okay. Second, whether the lesion is, if they're in the lesion, whether it's normal or abnormal. So this is the most common reason why we get evaluations for neurosurgical samples. And second is this surgically treatable condition? Is the rapid diagnosis possible? Can we do the complete resection? Sometimes it is possible. For ependymomas, for example, if you tell it's ependymoma and there's a good plane of resection, gross total resection gives you best outcomes compared to the partial resections. Then they want to see sampling adequacy, then tissue available for ancillary studies. Sometimes you're not doing core biopsies. You may not have enough to do a lot of studies, IHC, molecular, you name it. Today's day and age, we are having so many ancillary tests being done for diagnostic implications. Okay. Then the next they want to know is whether their clinical impression is confirmed or not. Okay. And there is last disorder, which I really love this. I call it as frozen compulsive disorder. Some surgeons just want to know what the heck they're doing. They are so restless without the frozen. For every case they cut open, they send for a frozen. But that's okay, because see, that's why we are here and we are serving a purpose. It's okay because you take everything in. Okay. So, but on a busy day, this can be really treacherous. Why are you calling me for a schwannoma? You go, it is a schwannoma. But it just gives them we are like diazepam, or should I say pandy for them. So it will reduce their heartburn and they will go on with their day. So this is the last, and many times, many places I have come across surgeons who are giving just for this reason, FCD, what I call frozen compulsive disorder. People who are having friends in psychiatry will know what I mean. This is the DSM manual. So talking about stereotypes, you see, I'll tell you where the tissue see, every time pathologist gets a bad rap. What is this pathology report coming? Why are they giving us like this? Why are they giving it's not representative this, that? Most of the time, poor pathologists report what they see on the slide. They cannot diagnose what they don't see. Okay, so if your surgeon is giving you correct, so part of the reason why I'm wrong is because you are wrong. You have given me the wrong area. So the near mass. So if you take the needle goes at the periphery of the lesion, even a malignant neoplasm will look very benign, okay, or low grade, because that's the infiltrating edge and you don't see all the features. So you tell them in such a way that if you have a good a grip on the neuroimaging, you tell, sir, this is looking like a high grade glioma on the imaging, but on the frozen it's looking low grade. Please advance your needle either medially, laterally, or deeper. You will get the correct representative section. So that's another reason why stereotactic biopsy or the intra-op consultations are warranted. Okay, so general principles, what you have to, when you get a sample is very delicate. Okay, you have to be very, very cautious and treat it with lot of respect. So when you want to perform a cytologic preparation is done as a complement to frozen tissue section. Don't render diagnosis on cytology. Okay, smears. And second thing, don't freeze all the tissue. Third thing, when you don't know what the diagnosis is, when it's a global phenomenon, you better keep some tissue in glutaraldehyde because you may need to do EM later. Okay, and for minute biopsy samples, what you do is that you don't have any much tissue at your disposal. So when you inform the histotechnician saying that when you're cutting, please save in between sections for additional workup. So this is how you triage the cases and make maximum of what you have at your hand. Okay, so intraoperative, see, we can do touch imprint smears, squash smears, drag and scrape. So there are different ways of analyzing cytologically the brain tissue sample. Okay, so this is how we freeze it. This is the picture that was this is actually my hands here doing the things. And I'm seeing, you are seeing me how I'm doing the smear preparation. Put the tissue on the slide and cover it with another slide. Just put enough pressure so that your nails will blanch. Okay, and then you pull them apart. All right, so that is how you do the smear. And this is the heat extraction method for freezing. You freeze a little bit of OCT, then you place the tissue and place some more warm OCT and immediately freeze it with a cold chuck or a steel weight, and the heat dissipates so fast and you can immediately freeze, because brain has a lot of water content and it is going to be, can you please switch it off? Sorry, keep it in silent mode, please. So what will happen is, so the heat is dissipated and it immediately freezes. So this will reduce two things. First, you save time, and second, you reduce lot of freezing artifact. I'm telling you. So this is the algorithm I typically follow when I'm dealing with the frozens. So first I have a tissue, whether normal or abnormal. If it is normal tissue, not representative, ask for more. If it is abnormal, whether it is neoplastic or non-neoplastic. If it's non-neoplastic, see whether it's a representative section of a non-neoplastic process, and then look at the suspects. Okay. Then next is the neoplastic. If it is neoplastic, whether it is representative, whether there is tumor there or not, and if possible, if there is tumor, you can tell the tumor grade. Okay. So then here is a smear. This is the smear from a cortical tissue. You can see the neurons here, and there are glial cells. There's oligos in the background. You can see the neuropil as a pink structure. Here you are seeing only the oligodendroglial cells, and this is the neuropil in the background. This is white matter. Okay, this is the cortex. Will have mix of both. On the left hand upper panel, you can see there are black arrows are there. They are pointing at the neurons, and then the smaller looking cells are the glial cells. Right hand side upper panel, it is showing only the oligodendroglial cells, and the pink background is basically neuropil. And the meningioma, you can see beautifully the whorls are there, and then this is a meningioma smear. So here you can see pituitary. If at all you have to forego frozen section and be done with only the smear, that's the only place I will do is pituitary adenoma, because it will save a tissue. Many times we don't have much tissue in pituitary neoplasm, we don't get much because it gets sucked out. And you can see monotonous appearing cells, and on the high power you can see beautifully the rounded nuclei with the indistinct nuclear and heterochrome, salt, pepper, chromatin, what we call it as. So this is the only place I will forego doing frozen section, but otherwise each and every case smear and frozen section is a must. Smears will tell you the nuclear morphology, and frozen will tell you the actual morphology of the tumor. Okay, because freezing artifacts accrue and nuclear morphology is compromised in frozen sections. That is why smears will help us, because they are not frozen and they maintain the nuclear morphology. So this is the problematic frozen section specimens. What do you do? What are the problems you face, and what are the recommended procedures that you have to know? When it's a minute sample, best to do a cytotouch prep or a drag preparation before freezing the tissue fragment. Okay, cauterized tissue is there. You take the scalpel, dissect it, and the fresh surface you freeze it. Okay, if the fibrous or desmoplastic tissue, scrape the tissue section before freezing, so that you will have a better quality of the section. When the petri dish of full necrotic tissue, what you do is you take multiple fragments, put it on a slide, and drag all the fragments as much as possible, so that the sampling will be good. And if it's a bone tissue fragment, you just do a cytologic drag preparation. Tell him it's difficult to freeze a bone tissue, and whatever you do your best and keep moving. Okay, so what are the artifacts? Artifacts are innumerable, and you can be challenged so many times. You can be frustrated, you can make wrong diagnosis. A lot of things can go wrong because of artifacts. Okay, so here is one such. This is oligodendroglioma. Crystal artifact has made it look like an astrocytic. This one, after fixation, this classical fried egg appearance develops, and you can know that this is a oligo. But on a frozen section, it is very difficult to tell. You just tell, sir, it is a atypical glial cells are there, most likely a glioma. Difficult to tell whether it's astro or oligo, but I'll defer it to prominence. Do that. Nobody will hold you a gun at your head. Okay. This is a freezing ice crystal artifact. I was telling you, 70-80% of the brain tissue is water. If you don't freeze it fast, this is what you end up with. This was a pilocytic astrocytoma. Look at the crystal artifacts that it has introduced. Okay, freezing, and it looks like a diffuse glioma. So you can go wrong many places if you don't exercise caution. Bone dust, many times it is called as artifact. There will be sponge tissue. That time also they get called wrongly. So this is the bone dust, which can be misinterpreted as dystrophic calcification. Okay. Many a times necrosis is confused with poor staining, especially when there's no hematoxylin at the edge. Only eosin is there. You can easily go down the tubes, causing it necrosis. Necrosis in a tissue means high grade tumor.